Thank you, sir. Very good evening, everyone. So, before I start, I would just say that I have a really bad throat. So maybe I went a little overboard, cheering up for the Javed Ali show yesterday night. So just bear with me. So abducent nerve palsy. So just brushing up the basics. The sixth nerve palsy, I guess, is the most common acquired oculomotor palsy that you will see in your clinics. So there's a very simple textbook diagram which all the PGs they know about, but this that you must know. This gives you an idea about the localization. You can localize the exact where exactly the pathology is. So if you look at this, just quickly brushing this up, that the nucleus is present at the level of the pons. It's present in association with very important structures. So you have the seventh nerve, the PPRF, which is the horizontal gaze center, the pyramidal tract. So based on this, you will know that if there's a nuclear or a fascicular involvement, it cannot be isolated. So look for those neurological signs, like a gaze palsy, a seventh nerve dysfunction, hemiparesis, along with the sixth nerve palsy. So giving you an example, this is a beautiful video. This young female patient comes to us with a problem of movement in the horizontal gazes. So as you can see, there is a bilateral gaze palsy, horizontal gaze palsy. The vertical gazes are intact. The convergence was also relatively intact, but on dolls, the abduction was affected. You also see a facial nerve involvement. As you can see on the photographs, there is a lag of thalamus, the drooping of the corner of the mouth. So this was a case of a horizontal gaze palsy, sixth nerve palsy, and a seventh nerve palsy. So where do you localize the lesion? It has to be in the pons. You get a neuroimaging, order the neuroimaging accordingly, and we found this pons angioma. Now, the sixth nerve could be associated with certain syndromes like Mobius syndrome, where again you have multiple cranial nerve involvements. The neuroimaging usually shows a hypoplasia, so be aware of that. Then this is another patient, young patient, presents to us with a bilateral sixth nerve palsy. But along with this, he also has complaints of blurring of vision and severe headache. Now, fundus exam is a very important aspect in case of a sixth nerve palsy. So we did that. The patient has a bilateral disc edema, immediately ordered a neuroimaging. So this patient has a prominent optic nerve sheaths, partially empty sella, and CSF manometry revealed a raised intracranial pressures. So this is a case of IIH. Now, raised intracranial pressures, either related to intracranial space occupying lesions or maybe IIH, can cause sixth nerve palsy, and that's a false localizing sign. So remember, do a fundus exam in case of acute sixth nerve palsies. And why does it happen? The compression is happening somewhere here, where the sixth nerve is entering the Dorello's canal. So because of this acute angulation in the subarachnoid space, it just gets compressed. Then if it's a cavernous involvement, again, it will not be isolated. You will have third, fourth, fifth nerve involvement. If it's orbital, look for orbital signs like a chemosis or a proptosis. Like this child comes to us with a right-sided sixth nerve palsy. But what you also notice is a proptosis. So we did a neuroimaging, and you see this beautiful cyst lying over here. So it was a case of myocystic And this was also shown on ultrasound. And this, because the management totally changes. You need to identify what's the underlying cause. Now here the patient was treated with anthelminthics, and at 6 months post-op, 7 months, she's doing pretty well. So whenever a case of any acute palsy comes to you, you must first identify what's the underlying cause and treat that cause or refer the patient for the same. Meanwhile, what you have to do? You have to give conservative measures to alleviate the diplopia. So patching, prisms, and botulinum toxin. So I guess acute sixth nerve palsy is an ideal indication where you give the botulinum toxin. So this is the botulinum toxin that we use at a center. This is pharmacological. This is actually prepared at a center by the ocular pharmacology department. And we just load it in the tuberculin syringe and give it to the patient. So it has a very dual purpose. One is that it elevates the diplopia, at least in the primary gaze. And second is that it prevents the antagonist, which is the medial rectus, from going into the contracture while we are waiting for the sixth nerve to recover. So this is one example of a Botox patient, pre and post. So the patient is, of course, it works very well. The patient usually happy, except from the extremes of gazes, that is an abduction, might have a little diplopia, but most of the cases they are doing well. And complications are very minimal. You see a little subconch hemorrhage, maybe a mild ptosis, and that's usually reversible. Now, if the sixth nerve palsy does not recover at 6 or 9 months, it is then that you have to consider surgical management. Now, what surgery? It will depend on a lot of factors. Now let's have a look at this case. This is a young patient, has a sixth nerve palsy. So not much of a ESO, and look at the LR action. That's pretty good. So a good LR action. In such a case, MR not very tight, you can do a recess resect or a recess plication procedure. But remember, unlike comitant strabismus, you might have to plan a little more. So supramaximal recessions along with plications. Another case, patient has a large angle ESO, marked limitation of abduction. Now on FDT, the medial rectus was found to be tight. Now in this case, whenever there's a tightness in the antagonist, first release the tightness. So we did the medial rectus recession, but that was not enough because the patient has a large angle ESO. You need to augment it with a transposition procedure. So we did a partial vertical rectus transposition. This is the pre and post. And as you can see, not only the good alignment is achieved, the abduction also improves considerably. So that is how the transposition helps, as Dr. Rohit was discussing in DRS. Now, partial VRTs we were earlier doing, but now we have, shifted to SRTs, which is single tendon transpositions. And here again, similar case, marked limitation of abduction. And the patient, you see, is not only well aligned with MR recession and SRT, good alignment, but also the abduction tends to improve. So SRTs also give very good results, just like partial tendon VRTs. So essential, the goal or the aim of surgery in paralytic strabismus would be to eliminate the diplopia in maximum gazes and to achieve a binocular single vision, at least in the primary gaze for the patient. So this is the algorithm for the management of sixth nerve palsy. So 3 important factors that you must consider is how much is the duction beyond the midline, that how much is the eye going beyond the midline. So this gives you an idea what is the LR action. Second, if the MR is tight on FDT. If it is, you will have to do a MR recession. And if whether LR action is there on active force generation test. So if LR action is present, you can do a recess resect procedure. If there is MR tightness, you will have to do MR recession. And if LR has minimal or no action, you will need to augment or you'll have to do a transposition procedure to improve your abductions. Now, what are the types of transposition procedures? Well, vertical rectus transposition, it could be either double tendon or single tendon. Now, single tendon could be superior rectus or inferior rectus transposition, and double tendon could be full or partial tendon. And all of these transposition procedures could be augmented by either a MR recession, Foster's, or Botox. So these are the various types of, just a diagrammatic representation of these various types of procedures: a full tendon VRT, a Foster's modification, Jensels, Hamilsheims, Nishida. Now Nishida is a very interesting procedure because here you are just splitting the 2 vertical recti and transposing them laterally without disinserting. So there is less risk of anterior segment ischemia. Now, in the single tendon VRTs, superior rectus transposition is more commonly advocated, and this also carries less risk of anterior segment ischemia because you are not touching both the vertical recti. But since it's creating an imbalance in the vertical forces, there is a theoretical risk of inducing vertical and torsional diplopia. Now, we did this study, and we found that none of our patients actually had any diplopia, torsional or vertical. And somehow it tends to balance out. And what we also noted is that in long term, the effect tends to improve. So if there is a mild undercorrection in the immediate postoperative period following SRT, that you can expect it to improve over time. There are very rare case reports of certain torsional and vertical diplopia. And less commonly advocated is the inferior rectus transposition that has been done only in particular or very specific cases like patients of LR palsy with hypertropia, encyclotropia, or a V esotropia. So giving such an example, this case recently presented was a young boy. As you can see, there is a sixth nerve palsy. But also what you see is a bilateral SO palsies, marked excyclotorsion on the fundus, and there is a V pattern. So we had to deal with the inferior obliques. We had to recess inferior obliques, so we could not risk doing another elevator. So that's why here in this we thought of doing an inferior rectus transposition along with bilateral IO recessions. And this is the post-op result of the patient, which is pretty acceptable and very good results. So because we were a little earlier, hesitant about doing IRTs, but I think you must choose your cases wisely, and it may have certain specific indications. So we published this systematic review about the vertical rectus transposition procedures for lateral rectus palsy, and we found that quite interestingly, the full tendon VRTs, the partial tendon double VRTs and single tendon VRTs are more effective than full tendon VRTs. So I think that's all about the sixth nerve palsy. Thank you.
Thank you.